Your heart muscle, or your heart, is also called the myocardium. And the coronary artery blood flow to the myocardium occurs primarily during diastole. And diastole is when your heart is resting and all the veins and arteries are filling back up. So to maintain that adequate blood flow through those coronary arteries, you have what we call a mean arterial pressure. And that mean arterial pressure must be at least 60 mmHgs, and that is to maintain adequate blood flow through the coronary arteries and help perfuse all your major organs like your brain and your lungs and your liver. So if the mean arterial pressure gets below that, then your organs are not getting the oxygen that they need, and tissues start to die. So some of the mechanical properties of the heart that we're going to discuss are the cardiac output, the heart rate, stroke volume, preload, impedance, myocardial contractility, cardiac index, and the cardiac index normal range. So just a little refresher, remember that your systole, which corresponds with your systolic blood pressure, consists of the contracting and the emptying of your atrial and your ventricles. And your diastole is approximately 2/3 of your cardiac cycle, so that's the majority of your cardiac cycle. And your cardiac cycle is one full heartbeat, and that consists of the relaxing and filling of your atria and your ventricles. So your cardiac output, or your CO, is the amount of blood pumped from the left ventricle each minute, and that's all it is. But the cardiac output depends on the relationship between your heart rate and your stroke volume. In most adults, your cardiac output is about 4 to 7 liters a minute. Realize that your cardiac output can vary according to your body size and whether you've got any heart damage or not. And then so some of the cardiac output has to be adjusted for changes in the body size. We all know your heart rate is the number of times the ventricles contract each minute. Your normal heart rate, resting heart rate, is about 60 to 100 beats per minute. Something else to realize too is your heart rate is controlled by your autonomic nervous system, and I think we've talked about that in the past. And your stroke volume is the amount of blood that flows out of your left ventricle during each contracted. So each time that heart contracts or those ventricles contract, it's the amount of blood that it's pushing through that left ventricle. Preload is realize you have all of these heart fibers that stretch at the end of diastole, and then just right before that heart begins to contract again. So preload is the degree to which those fibers are able to stretch after the heart starts to relax, and then right before it starts to contract again. Your preload is determined by the amount of blood that's returning to your heart from both your right heart and your left heart. So that's both your venous and your pulmonary system. Impedance, I'll come back to that one in just a moment. Something on here that is that I don't have listed on here is called afterload. This is another one of those things that helps to affect your stroke volume. It's the pressure or resistance that your ventricles must overcome to be able to eject blood through your valves and into the blood vessels. The amount of resistance that's there is directly related to your arterial blood pressure and the size of your blood pressure, of your blood vessels. Impedance is the component that comes after the afterload, and it's the pressure that the heart must overcome to open the aortic valve. The amount of the impedance can depend on how your valves are functioning, any type of resistance from your vascular system, and a combination of the blood thickness and how the arterioles are constricting. Your cardiac index is your cardiac output divided by your body surface area, and I don't expect you to have to remember that or be able to calculate that. And then your cardiac index normal range is about 2.7 to 3.2 liters per minute. So I've already said your cardiac output is the amount of blood pumped from your left ventricle per minute, and it's can be a combination of your heart rate times, there is a combination of your heart rate times your stroke volume equals your cardiac output. So let's talk a minute about blood pressure regulation. So in your autonomic nervous system, you have these receptors called baroreceptors, and they're located in the arch of your aorta. And anytime a patient gets or is having problems with hypertension, the baroreceptors send impulses through your vasomotor system, and these impulses make it possible to signal the body to start to drop the blood pressure. So just remember about your baroreceptors is that they help to drop your blood pressure when you have an increase in your BP. The chemoreceptors are they're collections of tissues in the carotid arteries, and they're called peripheral chemoreceptors, and they're real sensitive to hypoxia. So anytime that there is a decrease in a patient's oxygen level, these chemoreceptors send impulses along the vagus nerve, and they help activate a vasoconstriction response and raise the blood pressure. So the chemoreceptors signal these impulses, and these impulses are sent along that vagus nerve, and then everything starts to constrict and helps to raise the blood pressure. Hypercapnia is an increase in your PaCO2 level, and it causes a patient to be acidosis. And it's basically the direct effect of carbon dioxide on the central nervous system. And then the renal system and blood pressure. We all know that blood pressure has a significant effect on patients who have hypertension, especially if there is already kidney involvement. And the kidneys help regulate our cardiovascular system. When your renal blood flow or your pressure decreases, remember your kidneys will retain sodium and water. Your blood pressure tends to start rising because our bodies start to retain fluid. We have the activation of our renin-angiotensin-aldosterone system. This mechanism results in vasoconstriction, sodium retention, thus we have fluid retention. And then you also, the kidneys are helped regulated by the release of the antidiuretic hormone vasopressin. So that's where our endocrine system come in. Some of the external factors that can also help affect our blood pressure, things like pain, anger, exercise can affect our blood pressure, body temperature. Patients who are hypothermic causes their blood pressure to fall. So you can see where a lot of things can affect our different systems. So just taking a quick look at our cardiovascular system assessment. As always, we need to do a full patient history. Want to get any information we can about their risk factors, any type of cardiovascular disease, whether they smoke, whether they're overweight, their gender, ethnicity, family history, any chronic diseases that may put them at risk, cardiovascular disease. cigarette smoking, how much they smoke, whether they have a sedentary lifestyle. That's a major risk for heart disease. And just then making sure we're doing a complete, head to toe assessment. Nutritional history, what's their diet like? Are they drinking enough water? Doing dietary restriction? Doing supplements, vitamins, things along those lines. Do they eat or drink a lot of sugar, fiber, fat? So we just basically need to know how their current diet is. Some things that may show that they're already having symptoms of cardiovascular problems: shortness of breath, dyspnea on exertion, orthopnea. Remember, that's where they have to sit up on pillows to help breathe. PND is paroxysmal nocturnia dyspnea. That's where they've been laying down for several hours, and they'll all of a sudden, all of the blood from the lower extremities is redistributed, and it causes venous return to the heart. So then they start waking up and they don't feel like they can breathe. They may have a lot of extreme fatigue. It may be described as a feeling of tiredness or weakness from activity. Activity may take longer to complete. And this may be fatigue with like just mild activity. They may not be able to walk from their house to their mailbox without feeling just extremely tired. And this is due to a low stroke volume. They can have palpitations, feel like a fluttering or an unpleasant feeling in their chest. It can result from a change in heart rate, or they can have heart rhythm problems. Can come from premature contractions in the heart, sinus tachycardia. The heart's not pumping like it should. That's any heart rate below 60. Sudden, they can have a lot of swelling and edema, syncope. That's a brief loss of consciousness. The most common cause is decreased blood flow to the brain. Near syncope is basically a dizziness. The patient can't stand upright or can't remain in an upright position. So we want to understand, what kind of circumstances, what they were doing when that led to that dizziness or the syncope. And of course, extremity pain. It can be caused by ischemia from coronary artery disease, or from the peripheral blood vessels not getting enough blood flow. There is a term you need to know called intermittent claudication. That's basically where you have a pain with rest, and a lot of times you feel it in the back of your legs. You see intermittent claudication a lot of times with DVTs. And it's leg pain also from prolonged standing or sitting, and it's a loss of blood flow in those areas. In my nice little chart here, remember that your best indicator of fluid balance is weight. 2.2 pounds equals 1 kilogram, or 1 entire liter of fluids. Remember, a bag of IV fluids is 1,000 milliliters, or 1 liter of fluid. So that's a lot of fluid for a patient to have in their system. So a general appearance of the cardiovascular patient. How do these patients look? Do they look tired? Look at their build, appearance, skin color. Do they look distressed? Are they having any trouble breathing? Their level of consciousness, position, how are they responding to you? There is a term called anosarkia, and that's a generalized edema. It comes from problems with their liver. So just know that anosarkia is generalized edema. And it comes from late signs of severe right-sided heart failure. Cyanosis and rubor. You know what cyanosis is? It's a bluish or darkened discoloration of the skin. You see it in light-skinned people. It results from an increased amount of deoxygenated hemoglobin. It basically means everything's not getting perfused like it needs to. Rubor is a dusky redness that you will see in the patient's foot. It comes from arterial insufficiency. And so basically, like I said, it just looks like that foot is red and it's just not getting enough blood flow. Hypo or hypertension, what's causing that. And then postural orthostatic hypotension. Remember that orthostatic hypertension is a 10 to 20 point drop when you take the patient's blood pressure sitting and then stand them up. They can have a 10 to 20 point drop. Want to look at these patients for clubbing. Clubbing of the fingers is caused by these patients not getting enough oxygen in their body tissues, and this is a chronic problem. Remember, with clubbing, your nail straightens out to an angle of 180 degrees at the base of the nail, and that base of the nail becomes spongy. And we've talked about that in the past. This is common in patients who have COPD, chronic heart defects, or right-sided heart failure. And right-sided heart failure is also called cor pulmonale. It's just another name for it. Peripheral edema is also noted in the legs and feet in patients with cardiovascular problems. And the level of the edema kind of helps determine where the cause is coming from, whether it's, stage 1 or 2, whether it's pitting edema. So that's kind of how you help know where it's coming from. Precordium, assessment of the precordium. Your precordium is just the area over your heart where we as nurses will be listening and inspecting, palpating, and percussing those heart sounds. In most settings, we as nurses will hardly ever perform a precordial palpation and percussion. We just generally listen for the heart and lung sounds. Critical care nurses tend to do this more. So just know that that is an assessment process that you may or may not go through. Just a couple of things to remind you about is I just lost my train of thought. I apologize. Remember your point of maximal impulse that's located in the left fifth intercostal space in your midclavicular line. That's where you tend to hear the heart sounds the better. We've already discussed all of the normal heart sounds and the splitting gallops, and I don't think I discussed the pericardial friction rub. Rubs are very transient. That means they kind of come and go, and it starts in the pericardial sac and occurs with movements of the heart during the cardiac cycle. Pericardial rubs are a sign of inflammation, infection, or infiltration, and they can hurt in patients who have had a myocardial infarction or post-thoracotomy. This is left-sided heart failure. Left-sided heart failure is the heart failure that you will see the most. And it generally tends to have the more side effects with it. So I like pictures. So this shows that you can have, of course, that paroxysmal nocturnal dyspnea. You can have pulmonary congestion with a cough, crackles, wheezing, blood-tinged sputum, tachypnea, restlessness, confusion, because that heart's just not pumping the way it should, orthopnea, tachycardia, fatigue, cyanosis. And if you will get in your basics book, your blue Kaplan basics book on page 116, it goes through all of these side effects and why they occur. So I'm not going to spend a whole lot of time on why all of the side effects occur from left-sided heart failure. but just realize it is the heart failure that you tend to see the most. Most of your signs and symptoms do come from a decrease in the cardiac output and involves a congestion of the pulmonary circulatory system, the venous system, or both. Almost all of your signs and symptoms affect the tissues and the organs that are located away from the heart. So they're affecting your lungs, your kidney, your brain, your liver, and your extremities. So this is the right-sided heart failure, also called cor pulmonale. And as you can kind of see with your right-sided heart failure, most of the things you see occur in your extremities, like the dependent edema occurs in your the extremities of your hands and the extremities of your feet. You can see an enlarged liver and spleen, ascites, which is fluid in your belly, distended jugular veins, and so that's kind of how you can tell the difference. You have more, your signs and symptoms are more severe with the left-sided heart failure, and that is the one that you see most with the majority of your patients. Right-sided heart failure victims can, right-sided heart failure develops from a right ventricle that's diseased. It causes backward flow to the right atrium in your venous circulation. It almost always follows left-sided heart failure because of the stress placed on the right ventricle as it continues to pump against the resistance. The venous congestion causes all the peripheral edema and the congestion of the organs. So some of the lab values that we'll see with heart disease and heart failure. Your troponins are muscle markers. It's they checked the myocardial muscle. There's a protein that's released into the bloodstream when the cardiac muscles have been injured, especially after an MI. These troponins, they're not found in your, normal, everyday, healthy patients. So any rise in these values can indicate that there's cardiac tissue that is dying. Creatinine kinase, or CK. These are specific enzymes. They're specific to the cells of the brain, the myocardium, which is also your heart, and then the skeletal muscles. So it's not always, the creatinine kinase is not elevated in just patients who have had a heart attack. It can be, it just indicates tissue injury. So even people who run a lot and exercise a lot and they've been like overdoing can have elevations in their creatinine kinase because they have muscle tissues that have had some injuries to them. But it can be an indication to heart tissue injury. Myoglobin is an early marker, again, for a heart attack. It's just a protein found in the cardiac and skeletal muscle. And it's the earliest marker that is detected. And it can be detected as early as 2 hours after a heart attack, and then it starts to decline after about 7 hours. Realize myoglobin is not cardiac specific, but it can be very helpful in detecting the stroke. Excuse me, heart attack. So then we look at our cholesterol, our lipids. Our total cholesterol we want under 200, triglycerides under 150. Remember, your HDL is your high density lipids. Those are the good lipids. Those are the ones that actually are cardioprotective. That means they protect the heart. We want those greater than 40. And then our LDL, or our low density lipids. And those are the ones that are kind of bad for us. And we want them less than 70, especially if you're a cardiovascular patient. Homocysteine is an amino acid, and it's produced when proteins start to break down. So you have a normal amount of homocysteine that's present in the blood, but anything that is really elevated can be a risk factor for the development of cardiovascular disease. So that's where that particular amino acid can be valuable. And then a high sensitive C-reactive protein You see high C-reactive proteins in anybody that's got any type of an inflammatory disease, especially like rheumatoid arthritis. So as you know, we have a lot of inflammatory processes going on, especially when patients have had a heart attack. Now, but realize the elevations can also be seen with high blood pressure, infections, and smoking. So it just is helpful in determining patients who are at risk for coronary artery disease. So more laboratory assessment, and I'm probably not going to go over all of these. Remember that microalbumin is your earliest indicator for kidney disease. And microalbumin is just small amounts of protein in the urine, but once you start seeing that, then you need to be checking the kidneys, doing other lab results to see what the problem is, and especially if patients have hypertension or if they have diabetes. The NRPT, INR, those are blood clotting disorders, ABGs. And F&E is a fluid and electrolyte balance. Not sure about that specific test. I'll have to come back to. I think it's just saying to make sure your fluid and electrolyte are an imbalance, because that's a necessity for normal cardiovascular function. Erythrocyte count, remember that's your red blood cell count, and it can be decreased with things like infective endocarditis. That's an infective of the heart muscle, and it is increased in heart disease because it's needed because you have decreased oxygen, so you're going to have a decreased red blood cell count. Your H&H is your hemoglobin and hematocrit. We know since we don't have all of the red blood cells to carry oxygen to the body, then those results may be low as well. And your leukocyte count is your white blood cell count, and that's typically elevated after a heart attack. And it can also be elevated in infections and infections processes. So how are we going to diagnose these particular patients? A chest x-ray, PA and lateral chest x-ray, also an angiography. Realize that your chest x-ray helps to determine the size and the position of the heart. In the angiography, they'll a lot of times we're doing that looks at your arterial vessels and lets them know if there's any constriction going on in there, if there are any blockages. An arteriograph is an invasive diagnostic procedure. It involves going in there and using contrast to see if the vessels are narrowing or if an aneurysm is expected. A radiologist performs this specific test. Then, of course, I think most of you have heard about cardiac catheterizations. And I have a picture on the next slide here that shows that. As you can see, the cardiologist will go down through the femoral artery here and insert a wire up through there so that they can see if there are any blockages. And if just notice whether the person needs a stent or whether the blockage needs to be cleaned out. These patients have to be NPO after midnight. I don't think they can smoke prior to. And then there are standard precautions after the cardiac catheterization that they have to lay still for a certain amount of time and can't move whichever leg that they used to do the cardiac caths with. Other diagnostic testing that we'll have is an ECG or an EKG, and that can look to see whether the patients have any arrhythmias going on. An EPS study, which is an electrophysiologic study. This is an invasive procedure, and it's where they go in and manually stimulate the heart, and it helps to evaluate patients who already have arrhythmias or conductive abnormalities like SVT, doing this procedure just helps find an accurate diagnosis and helps in effective treatment. Stress test, you can have what they call a walking stress test where the patients are on the treadmill walking, or they can do what they call a chemical stress test for those that can't handle the exercise, and the patient will basically sit there and they'll inject a medicine known as adenosine, and then they'll just do studies at like every few hours or so to see how the body is reacting to the adenosine. These patients generally will have to be like in PO after midnight, and there are a number of limitations prior to their test. An echocardiogram looks at your valves and chambers of the heart and does what we call an ejection fraction and can actually tell how much the heart is functioning. A TEE is a transesophageal echocardiogram, and that's actually where these patients will swallow an ultrasound transducer. It's placed right behind the heart in the esophagus, and then the cardiologist can it will actually show detailed views of your cardiac structure, such as your left atrium and mitral valve, and it's just a little bit, it's invasive, but it tells them a little bit more than the echocardiogram will. And then your myocardial nuclear perfusion imaging, this is where any type of a cardiovascular event that the patient is having, this is a non-invasive test. And just one moment. Okay, sorry about that. The imaging tests are basically multiple tests that can be done to tell exactly where a patient has had a myocardial infarction. Generally, these patients can't eat or drink for 4 hours, and then they, of course, don't want them to have any cigarettes or caffeinated beverages. And this is a picture I just like. It gives you head-to-toe cardiac clues. You may have dry, brittle hair due to poor nutrition, vascular changes in your eyes due to increased blood pressures, lips and tongue, are they blue tinged? Think cyanosis. So this is just a good feature to a picture for you to look at. So hemodynamic monitoring. I'm not going to talk a lot about hemodynamic monitoring, but just be aware that this usually takes place in ICU. It's a more invasive monitoring for the patient, and it provides a lot of detailed information about how the blood system is flowing, the blood volume, how hard the heart is pumping, how much the tissues are being perfused, and generally a physician will have to go in and implant a specific catheter, either an artery or an arterial catheter, to help show all of these measurements for the patient. You don't really have to know a lot about hemodynamic monitoring. Just understand and realize that you do have a more invasive way of knowing exactly what your tissues are doing and how the heart is pumping and things along those lines. And this is a picture of an implanted catheter connecting to the tube and to the monitor here. So this is the end, but please just make sure there are multiple charts, and in this particular chapter, make sure you're looking at them because they definitely lay out this chapter very well. And also get in your basics book. This explains this probably a lot better than I ever could, and it will help you be able to remember some of the stuff better. Thank you.